Today on Derm School, we will be looking at a group of very fascinating disorders known as blistering disorders. First, we will review the histology of normal skin, and then we are looking at three disorders today, which are pemphigus vulgaris, bullous pemphigoid, and dermatitis herpetiformis. So if you recall, the normal skin is divided into the epidermis, followed by the dermis, and then hypodermis. And the epidermis is divided into your stratum corneum at the top, which is the horny layer, followed by stratum lucidum in the palms and soles, which is a clear layer, and then you have stratum granulosum, or the granular layer, stratum spinosum, the spiny layer, as well as stratum basale, which is your basal layer. The first condition we're looking at is pemphigus vulgaris. Pemphigus is an autoimmune bullous disorder characterized by loss of cell-to-cell adhesion in the epidermis, which is known as acantholysis. Pemphigus vulgaris usually starts in the oral mucosa, but less frequently with generalized eruption of bullae. The patient can develop burning and painful erosions with epistaxis, hoarseness, and dysphagia, as well as weakness, malaise, and loss of weight. As you can see here, pemphigus, it refers to a group of disorders, and pemphigus vulgaris can be both localized and generalized, but there are also other forms of pemphigus, such as pemphigus vegetans, drug-induced pemphigus vulgaris, pemphigus foliaceus, which also includes pemphigus erythematosus, phogosevagum, drug-induced pemphigus foliaceus, as well as paraneoplastic pemphigus and IgA pemphigus. For the morphology of pemphigus vulgaris, you first can appreciate vesicles and bullae with serous content which are flaccid and easily ruptured to form weepy areas, and this can develop on normal skin. Next, often you see erosions which bleed and then form crusts, especially on the scalp. The Korski sign refers to dislodging of the normal appearing epidermis by lateral finger pressure in the vicinity of lesions, whereas pressure on the bullae can also lead to lateral extension of your blister. The pattern for pemphigus vulgaris is random. Distribution, as we spoke about earlier, can be localized or generalized. Areas of predilection include the scalp, face, chest, axilla, groin, umbilicus, as well as the back, especially in bedridden patients. Mucous membrane erosions are often seen, involving the nose, mouth, pharynx, larynx, and vagina. Pemphigus vulgaris can be localized for months before progressing and becoming generalized. Patients will often die without treatment. However, now with effective treatment options, morbidity is related to glucocorticoids and immunosuppression. Investigations include skin biopsy for histopathological examination and direct immunofluorescence. So you can see a split in the epidermis, also known as a suprabasal bulla, okay? And on direct immunofluorescence, you can appreciate intercellular deposits of IgG and C3 within the epidermis. Next, you can send for serum autoantibodies, which are IgG, detected by indirect immunofluorescence or ELISA, and these are autoantibodies against desmoglein 1 and 3. So this is a picture of the suprabasal bullae. And this is direct immunofluorescence with deposition of IgG and C3 in the epidermis in a fishnet pattern. Management includes systemic glucocorticoids, as well as concomitant immunosuppressive therapy, which are glucocorticoid sparing. And options are rituximab, which is currently the first-line treatment option, mycophenolate mofetil, azathioprine, dapsone, methotrexate, cyclophosphamide, plasmapheresis, as well as high-dose intravenous immunoglobulin or IVIG. Other supportive measures include cleansing baths, wet dressings, topical and intralesional glucocorticoids. If you have documented bacterial infections, start antimicrobial therapy and correct fluid and electrolyte imbalances. Monitoring is clinical, both in terms of improvement of the skin lesions as well as to watch for development of drug-related side effects. Laboratory monitoring includes pemphigus antibody titers as well as hematologic and metabolic indicators of drug-induced adverse effects. Our second condition that we are exploring today is known as bullous pemphigoid. Bullous pemphigoid is another autoimmune blistering condition caused by autoantigens against your keratinocyte hemidesmosome proteins known as BPAG1 or BP230 as well as BPAG2 or BP180, and this is a condition often seen in elderly patients. There is usually a prodrome in which the patient presents with erythematous, papular or urticarial type lesions. Next, they develop bullae, and this can be small or large. They are usually tense, firm-topped, oval or round, with serous or hemorrhagic fluid contents. And the bullae in bullous pemphigoid can occur on normal, erythematous or urticarial skin. And sometimes you can also present with erosions. So you can see early lesions, which are your tense, small blisters. And then you can see here larger blisters as well as some erosions. Distribution includes lower legs, medial aspect of your thighs, groins, abdomen, axilla, flexor of forearms, mucous membranes. The pattern can be localized or generalized, but it is usually scattered. Group lesions can occur in an acidiform or serpiginous pattern. Initially, patients with bullous pemphigoid have moderate or severe pruritus, but later they develop tenderness of eroded lesions, and sometimes these areas can be large, bright red, oozing, and bleeding. And usually the bullae collapse to form crusts. Investigations include skin biopsy for histopathology and immunofluorescence, or IF. And on histopathology, you see the presence of a subepidermal blister. On direct immunofluorescence, there are linear IgG and C3 deposits along the basement membrane zone. Next, you can also send for serum autoantibodies, which are IgG, by indirect IF immunofluorescence or ELISA. And these are your BPAG1 and 2. Full blood count will also indicate the presence of eosinophilia. So this is a subepidermal bulla, seen on histopathology. And you can appreciate on direct immunofluorescence, you can see linear deposition of IgG and C3 along the basement membrane zone. Management. For very mild disease or local recurrence, you can use topical steroids or tacrolimus. However, most commonly, we have to start systemic prednisolone with some steroid-sparing agents. Most commonly, we use doxycycline with or without nicotinamide, if available. Other options are dapsone, methotrexate, azathioprine, mycophenolate mofetil, IVIG, as well as rituximab. Treatment options that are under investigation but may be helpful include omalizumab, dupilumab, secukinumab, which are biologic agents, JAK inhibitors, as well as a couple of newer agents such as bertelimumab or sutimlimab. So all these are still new and we are still investigating how they work. Lastly, we will take a look at dermatitis herpetiformis. Dermatitis herpetiformis is a chronic, recurrent, intensely pruritic eruption occurring symmetrically on the extremities and trunk. It is associated with gluten-sensitive enteropathy. Patients may have burning or stinging as well. The skin lesions are often arranged in groups, and these are erythematous papules or wheel-like plaques, tiny firm top vesicles which may be hemorrhagic, occasional bullae as well. And if the patient scratch, they have excoriations and crusts. And when the skin lesions heal, these present with post-inflammatory hyper and hypopigmentation. Sites of predilection include your extensor areas such as the elbows and knees, buttocks, scapula, scalp, and sacral areas. Treatment is with gluten-free diet and dapsone. So this is a picture of dermatitis herpetiformis. And with that, I thank you for your kind attention.